The College of Myeloma. So the College of Myeloma was established by the UK Myeloma Society to recognise people who throughout their career have made seminal contributions to our work on improving outcomes for myeloma patients in the UK. I'm delighted there are two people who are being awarded today I've known since I started working on the Myeloma 11 trial in 2011, so I'm super happy that it's them that we are recognising today. They're both going to give us a brief outline of their thoughts and their career, and we're going to start with Roger Owen, who is a haematologist in Leeds. He has been working in Leeds since 2001 and leads the flow cytometry diagnostic laboratory within and the whole of the hematological malignancy diagnostic service there, and has made an amazing contribution to our understanding of the use of MRD in myeloma that's been recognised not only in the UK and, as we heard, hopefully is now going to transition into standard of care, but has also impacted the meta-analysis of data that has led to the recognition of MRD as an endpoint in myeloma. So we're delighted to award and recognise Roger today.
Charlotte, thank you very much indeed. Thank you. Be interested to see if you're clapping when I've finished. So, I'm certainly a bit surprised when Gordon told me about this, but nonetheless honoured and delighted to be recognised in this way. So, he told me about this some months ago. He said, "You will have to speak at the autumn meeting, you know." I said, "Yeah, that's fine, that's fine." He said, "Well, what do you want me to talk about?" He said, "I don't really care, but keep it brief." So, hopefully I will keep it brief. And then this rather grand title arrived, Reflections on a Career in Myeloma. But so that sort of put me back a bit. But we'll see what we make of this. So these are my disclosures. This might not have too much structure. I've taken a few bashes on the head over the years, so my memory's not quite as good as it used to be. And I'll apologise to anybody if I've misrepresented any bits of their history. As someone once said, recollections may vary. Hopefully I'll do a better job of it than Steve Coogan. And obviously I'm well and truly into the grumpy old man phase of my career. So this did make me think about how did this all start for me. You know, why did I end up in Leeds? Why did I end up doing haematology? Why myeloma? And why MRD? So I'd like to persuade you all that this was some grand, systematic, and dare I say it, cunning plan. But I'm afraid it was nothing of the sort. And it was pure luck and chance and being in the right place at the right time. So my first piece of luck actually was being appointed to haematology in the first place, which was in 1991. So I have been doing haematology for nearly 35 years now. And the first piece of luck I had was that I turned up to the interview as the only applicant for a registrar job. So that was a good start. And the rest of it was, again, luck and being in the right place at the right time. So this is the Persian fairy tale, The Three Princes of Serendip, which I'm told is the derivation of the word serendipity. So lots of things happened in the early 1990s from which I benefited from. In 1993, the Myeloma 7 trial was the first trial that was run out of Leeds CTRU. Gareth Morgan was appointed as the first academic appointment in Leeds around about the same time. The Leeds HMDS was formed in its more or less current structure at that time point. And I also started working with Andy Rawstrand, who started his career as an unpaid helper in HMDS around about the same time, and we've worked together ever since. So just as a bit of background, what was happening in 1991? It was the first Gulf War. It was actually when the internet started. The internet went live for everybody in 1991, August 1991. I was just reflecting the other day, I'm so glad Twitter wasn't around then, or I'd have got myself in real big trouble. We're also in the middle of the BSE crisis, obviously, and that had a big impact on haematology, ultimately. And for the youngsters in the audience, this is a Tory politician, John Selwyn Gummer, who was eating a beef burger to demonstrate how safe beef was in those days. 92-93 was the first season of the Premier League, and it was won by Manchester United. And where's John? John Jones. So I did tell him, and we can see fellow North Walian in the middle there, Mark Hughes. So that's a claim to fame of mine. I did play against Mark Hughes at school, so he was quite a bit better than me. The movies are pretty good. The early 90s was kind of when Tarantino was in his pomp, so Reservoir Dogs and the like and Pulp Fiction were the early 90s. And the music was great. So what about haematology practice in the early 90s? Yeah, maybe this is what it was. So the standard of care for myeloma in 1991 was, would you believe it, ABCM. So that is a combination of adriamycin and carmustine given intravenously on day 1, followed by oral cyclophosphamide and melphalan on day 2 in a 6-weekly cycle. So we did know a little bit about autografting at that time, because that was around the time when all this seminal work was coming out of the Marsden, but we didn't have randomized evidence to support autografting it until 1997, which was the IFM 90, and the Myeloma 7 trial, which recruited from 93 to 2000, was published in the early 2000s. So obviously myeloma care has been transformed in that time. In terms of other bits of hemonc, we were treating lymphoma with CHOP, and we were treating acute myeloid leukemia with daunorubicin and Ara-C, so some of our colleagues have not been quite so lucky. So in 94, I started working on MRD with Gareth as my supervisor, and I use that term with some provision, because he didn't really supervise. And I started doing fluorescently labeled fragment analysis as an MRD method. And this is something that Jenny was doing at the same time. And these were our first publications, and rather modest publications, and J. Clin Path, for instance. But in 1996, so these are nearly 30 years old. At that time, CD34 selection went through a phase, and that diagram to the right shows that CD34 selection did purge myeloma plasma cells from stem cell products. I was dead chuffed with that at the time, but it does seem rather quaint and historic now. At the same time, Andy was working on flow cytometry. He was working out plasma cell phenotype, so he did a lot of the early work on demonstrating that myeloma plasma cells had a different phenotype to normal plasma cells, and that was his first publication on that. That was 1997, so the following year. I couldn't find the PDF for this. This must be on some old computer of mine somewhere, and I couldn't get access to it the other night. And I was astonished that Wiley was still charging access for this. Why anybody would pay $62 to get hold of that, I would never know. So it was some time before we were able to demonstrate clinical benefit for MRD, and that, this is this paper that was from the myeloma 7 trial, and this was in the autografted patients in that trial, very modest number of patients, but the flow-based assay, which largely is the backbone of what we still do today, and that was published in 2002. So that was our first proper demonstration of outcome benefit for MRD. So again, 20 plus years ago, and roll on to late last year when we now do with following a range of meta-analyses and a whole huge body of evidence and data that we now have acceptance of MRD in a regulatory sense. So again, that's a very that's a good thing for us, and it's great to see that happening after such a long time. So what are my final thoughts? Well, clearly myeloma care has been clearly transformed, and Karthik's presentation showed you that it's an ongoing transformation. I'd like to say that the UK-based IITs have made real contributions to patient clinical care in a whole range of areas, and it's been fantastic to be involved with that. I think they also demonstrated the real importance of correlative science with all studies, so I think that lesson has been learnt. And I think the great thing about that is that there's real buy-in from investigators, so we're not really needing to chase samples now. People are just sending them. Certainly when we started with myeloma 7, we were forever chasing bone marrows. We were really trying to persuade people the importance of doing them. But there is a caveat here. In many respects, we've become a victim of our own success. We've got, it's really very challenging to do frontline studies in myeloma. It's very challenging now to do studies in refractory disease because people have had so many agents. You could argue that we've probably now got enough drugs in myeloma. It's probably very difficult to argue that myeloma is an unmet need now. We've got our clinics that are burgeoning with patients. It's a real challenge. And patients are never off drug. And that's, I think that's something maybe we should be trying to address. And we are using an enormous resource to treat these patients. And I was struck as we drove past UCL that if you're coming into UCL to have your bispecific or CAR T, you will be walking past a tented village of homeless people. So it does bring certain things into perspective. So I'll finish there. I'll thank you all. Great honour and delight to be recognised in this way. But I can safely wander off and check into the nursing home now and know that UK myeloma is in very safe hands. So, thank you.
Also lots of virtual clapping coming through on the platform.
Thank you very much, Roger. Now, on to our second awardee today. This is Professor Mark Drayson. It gives me a real pleasure to invite Mark because I did my first clinical trial with Mark's help 15 years ago. So Mark provided us with an intro, which I have to read out. Born on a farm in Cornwall with no IT, 1974 went to Manchester to learn some medicine and immunology with the help of Medicus Index. 1990 went to Birmingham as a clinical immunologist, did immunodeficiency blood cancer diagnosis monitoring for West Midlands, the central lab work, supportive care studies in myeloma, many of you would know, infection, renal, bisphosphonates. More importantly, Mark was very much behind developing, validating serum-free light chain tests and other immunodiagnostics, and led and still is leading translational lab research. Over to you, Mark.
Thank you very much. I'm conscious that Wendy isn't here, but I still have to say that getting married and the birth of our son was the most important thing. But this is a great honor, and thank you very much. I'm afraid my talk's going to be quite a bit drier than Roger's, although it has to be said, last night was quite wet, wasn't it? So, I guess looking here at the myeloma fourth trial, and it's a while ago, and 80 patients in the fourth trial were managed by a planned policy of greater than 3 litres of water a day. And these were the patients who presented with renal failure, still had a degree of renal failure after 48 hours of hydration, and they clearly survived much better than the comparative group in the third trial, who had much the same anti-myeloma therapy, but no conventional fluid intake. So you'll note that didn't require a 28-day prescription of 84 litres of water, which would weigh 80 kilograms as you took it away from pharmacy. It's free of cost, it's free of pharmacy, and it's free of the MHRA. So if you look at UK Biobank, 400,000 people tested for vitamin D, much the same demography as myeloma, and less than half were vitamin D sufficient, and a fifth were definitely vitamin D deficient. How many myeloma patients or patients with precursor disease get their vitamin D tested, let alone take vitamin D? I mean, vitamin D is not free, but with the Tesco's Club card, it's less than £1 a month. Roger talked about ABCM, and of course in those days, all patients got the same treatment, irrespective of age, frailty. There was no transplants. And what happened is you gave therapy until the paraprotein had come down and plateaued out. And once it had been stable for 3 months, you stopped treatment. And sadly, a third of patients didn't reach plateau, and you can see their survival curve there on the left, pretty poor. People under 65, a median survival of 8 months, and over 65 even worse. But in the bottom right-hand side there, you'll see that the duration of plateau was the same, irrespective of age, suggesting that the biology of the disease from the point of view of relapse is very similar. The problems arise when you're giving treatment during active myeloma. These are results of response in fourth trial going up into the 11th trial. Huge amounts of work here over nigh on 40 years. At the bottom there, lots of statisticians, David, Walter, Janet, Golnath, clinical trials units in Birmingham, and from the 7th and 9th trial onwards in Leeds, 120 or more units across the UK. Hematology teams recruiting patients, and more than 10,000, well, nearly 10,000 patients up to this stage recruited into UK trials, and so it's thanks to all of those people and the patients and their families. Survival in the trials, even on the right-hand side, in the old trials for the under 65s, and in the more recent trials, the people getting intensive therapy. And you can see the first improvement was in the 7th trial there, and then the 9th trial above that in red, and the 11th trial in green. But on the other side, on the left, you've got the over 65s and the non-intensives, and really not getting much improvement until we're getting into the 11th trial. Although having said that, half the people in the 9th trial there were having melphalan prednisolone, which shows the importance of fitness, and the 17th trial coming along. Free light chain response to 3-week cycles of myeloma therapy. At the bottom there, I'm suggesting you might have 60% kill in each cycle, and the free light chains would reflect that completely accurately. But if you look on the right-hand panel there for looking at response by IgG paraprotein, in the second cycle, more than half of the drop of paraprotein is due to the kill in the first cycle, and it gets ever more complicated as you go through the cycles. In this one, we're looking at the response to the first cycle of treatment. So we're looking at the reduction in paraproteins and light chains in the first 3 weeks. And of course, at the very bottom there, you can see free light chains coming down the most, IgA the next, and IgG the worst. It's nothing to do with the difference in kill rate, it's just the difference in half-life. And if you go up to the top of the panels there, you can see we've got 531 patients with an IgG paraprotein and lots of free light chains. And the response at the end of at the end of 3 weeks is much better for the free light chains, of course, than the paraprotein. The other thing you'll see there is that Drayson's been bullshitting, because the half-life of IgG is supposed to be 21 days or so. And so how come more than half of those patients have got more than half a reduction in their IgG paraprotein by 3 weeks? And the answer is because during induction therapy, IgG half-life goes down to about 11 days. That's probably relevant if you're giving daratumumab, etc. From an immunologist's perspective, being able to see daratumumab on electrophoretic strip suggests you've got 100 times more than you need to get rid of a viremia or a bacteremia, or to cause an autoimmune disease. But if you're ever thinking of reducing the amounts of these monoclonal antibodies, to reduce the dosage, not the frequency, and perhaps go subcut. So, some diagnostics. They are quite expensive. I know not expensive compared to the treatment, but they're still about 100 quid to do the immunochemistry. We developed free light in Birmingham in 2000 or so, polyclonal sheep sera in a lab analyzer. Then we moved on to using monoclonals in a multiplex assay in the lab, and then we put those monoclonals into a lateral flow device, which worked very well, and it compared very favorably with free light. We tested it against a lot of light chain only patients and non-secretors, and it was good for picking up acute kidney injury patients. Now, can you do a lateral flow device for whole paraproteins? Electrophoresis on a lateral flow device is probably going to electrocute you, but you can measure the total kappa lambda ratio, which has been done many times over the years. It's been discarded because sensitivity of electrophoresis is about 1 gram per litre, and sensitivity of kappa lambda ratio is about 5 grams per litre. But that doesn't matter for diagnosis of myeloma. So you'll see here, if you adopt a ratio, free light chain ratio of 0.1 to 7, and a M protein threshold of 10 grams per litre, that will identify 98% of 3,000 plus myeloma patients, and it will exclude most of your MGUS patients. So a cheap test like that might be useful in low middle-income countries, and I spent August going around sub-Saharan Africa hospitals. So there in that panel in Yaoundé in Cameroon, and I took the opportunity to see what diagnostics they had, and they didn't have anything for myeloma. Malawi, Blantyre, even poorer, no diagnostics for myeloma. Dar es Salaam, they were hoping to set some up in a private hospital. Kampala was the best. They had some stuff which broke down a lot of the time. So, you know, we get WHO deaths from myeloma in the UK, 3,200. Given their populations, very few myeloma deaths recorded in those sub-Saharan countries. Now, if you look at the percent aged over 65, it's not a high percentage in those countries, so they're not going to have as much myeloma. On the other hand, they're all black, so that's going to double the amount of myeloma. So on the right-hand side, I've sort of done a calculation of how many people are dying undiagnosed myeloma. Those who are diagnosed, it has to be said, are picked up at a young age and in an advanced stage. So moving from Queen Elizabeth Blantyre to Queen Elizabeth Birmingham, and Tracy Chan and Guy Pratt and Jen Heaney working in the labs there. Can we use lateral flows to monitor UK patients with myeloma and precursor disease? You need to detect a 25% change in levels. That's difficult to do if a lateral flow with a finger prick at home. Problems quantitating to that accuracy because of the hematocrit. You know, we're looking whole blood, not serum. And then how do you accurately measure the volume of blood that you're applying to the lateral flow? The answer is it doesn't matter because we're measuring the ratio of two analytes. We're measuring kappa lambda. So that's all doable and hopefully going to be tested in the next few months. And the last thing on diagnostics is the isoelectric focusing, so identifying monoclonal serotypes, which is very sensitive. You can get down to 10 micrograms per litre, and that's going to be, Jen tells me, UKAS's classified test for next year. So finally, last slide. Understanding the biology of precursor disease to prevent myeloma. Chris Bunce and I have written countless grants on this. We learned to celebrate submitting them because the outcome was never very good. But recently, we have got some money and we're doing it, and we're a year into it now and it's going really well, but I bet you've noticed that you're not out of work yet. Just a few observations here. MGUS tends to be resistant to myeloma therapy. We see this when you've got biclonal disease. You treat the myeloma, the MGUS in the same patient, getting the same therapy, doesn't respond so well very often. Biclonal gammopathies and fratricide, 5% of MGUS patients have two clones. When we looked at over 6,000 patients, central lab analysis, diagnosis of myeloma, less than 1% had biclonal disease. To my mind, that means active myeloma killed off the brother clone. Now, it might not be right, but Sigurdor on iStop is going to follow up his biclonals. He's got quite a lot of, so we can actually see if they do disappear or were they never there in the first place. But I also ask you, why don't we see second primary myeloma in myeloma patients? And I contest that it's because the active myeloma kills off the MGUS clone that might have caused a subsequent myeloma. And then finally, matricide is a partial responder. Is the residual paraprotein derived from the myeloma cells or its precursor disease? We don't know. I suspect it's from the myeloma cells. But it is interesting to find out how active myeloma might eliminate accompanying precursor disease for future studies. And on that final note, fratricide and matricide. My brother is playing golf in South Africa, and my mother is still on the farm in Cornwall, going strong at 94. Thank you.
what a fantastic session celebrating two of my favourite people in myeloma. So congratulations to both of you, and what a wonderful way to celebrate.